at the public health school and a master's on public health at the National University of Colombia. This is a regular space that we have every month to address some topics of interest in the field of public health and discuss with professors, specialists, and students. Today, we have decided to address the debate on the pandemic treaty because it is important on a world level in the field of public health. After 4 years since the pandemic was declared, and the years during which the INB, Intergovernmental Negotiation Body, was created to deal with pandemics, they have recently published the proposal of this pandemic treaty. This is being discussed at the moment at the INB in the framework of the next WHA, which will be held in May. It will be discussed and then perhaps adopted. So that's why we think this is a fundamental topic. And we've made an agreement with People's Health Movement to have this public health debate, considering how important it is for the region and in particular the Global South. We've had never known experience with the pandemic of COVID-19, and we had to deal with how big this situation was for the field of public health on a world level. So there are several things that we have learned from the situation, and it showed how unequal everything is in the world, and in particular, how hard it is for the Global South. Response was very different in the Global North and in the Global South. And the development of technology, medication, and vaccines was very unequally distributed all over the world. So we think that this should be different because we all have a right to health and nobody should be discriminated. And scientific developments should be available to everyone in the world, depending on how much they are needed and not how much money each country has. So we think this discussion is necessary for everyone in the world. And of course, this is something that should be discussed in the academia as well. So that's why we have created this space to have this discussion. This debate has been organized with PHM, with Dr. Roman Vega, who is also was supposed to moderate this session too, but unfortunately he cannot join us today. But maybe he can join us later when electricity comes back at his place. So we have organized this panel with different speakers. We have Dr. Juliet Alexandra Upegui Zapata. She's from the Public Health Department. She will introduce the pandemic treaty to us based on an international public health course where she participates. We have also invited Susana Barria. She is part of the Public Health International, so she can tell us what their mission is from health workers' perspective. We also have invited Gopal Kumar. He is a senior researcher, member of PHM, and also a member of Third World Network. He has been analyzing this treaty from this network's perspective and of course from the PHM's perspective. And because Ministry of Health wanted to, as part of the WHO, and will be, well, they will be presenting the Colombian state perspective, and we also want to thank them for participating. So they will be sharing the perspective of the Ministry of Health. Dr. Claudia Vargas will be presenting on their behalf, and we thank her for being here. So what we propose is the following. Each panelist will have first a moment to talk during 10-15 minutes, and they can express their opinion regarding the pandemic treaty. Then we will move on to a Q&A section. So the idea is that we finish around noon Colombia, so more or less in 1 hour 45 minutes. So I will give the floor first to Professor Juliet Upegui Zapata. As I mentioned before, she teaches at the public health school. She's microbiologist. She has a master's in biology and tropical diseases, has a PhD in pharmaceutical sciences, and also has a PhD from University of Antioquia. She has created the international health course. So Juliet, the floor is yours. Go ahead. Thank you, Dr. Mauricio. Can you hear me, right? Okay, so hello everyone. As Dr. Mauricio was saying, in our public health inter-school PhD course, we have created an international health course. And one of the important things to this course, also considering what's happening in the world, is the pandemic treaty. So I want to give you some context on what the pandemic treaty is. The pandemic treaty is this situation that has been happening because of the pandemic, which was something that happened for the first time on this scale. Give me one moment. Excuse me. So it follows the COVID pandemic and the way the pandemic was handled by each country. This showed how big the gaps are between countries and how they manage resources, and also the topic of solidarity. It was obvious that even though we had guidelines, the international health regulations, anyway, these didn't fully apply during COVID because the way it was handled in the global north and the global south, it was very different. We, in the global south, really depended on what was happening in the global north and how willing they were to help developing countries. So this was obvious, and in 2021, the Intergovernmental Negotiation Body, INB, was created with the aim of creating some guidelines that focused on this pandemic treaty. So this pandemic treaty would be an agreement, an international agreement that has the purpose of prevention, preparedness, and response before pandemics. And even though this doesn't appear on the title, the idea is that recovery is also included. And this would include how countries recover after a pandemic. There's a very beautiful thing in what happened before the treaty. What it supposes is that everyone knows what we should be doing and that there is solidarity among countries. But in a moment of crisis, this doesn't really happen. So at the beginning, it says we will not take anything for granted until it is granted. So the idea is that we have equity, we have a right to health to prevent pandemics, also to mitigate death. And in order to do that, we need some actions. And these actions focus on strengthening in a very active way in all countries that will allow having world capacity, both in the global north and the global south, so we can deal with it. So this sounds pretty. So we read this and say, okay, yes, this is beautiful. But then the discussion is which are the good points and which are the bad points, or perhaps they're not necessarily bad, but yes, they put us in a dilemma. So one of the things that I want to mention so that then we discuss is that it is a One Health focus. So it is very important that this perspective is very global, and we need to understand disease and health on in a holistic way. And this is important because it is very obvious how biotechnology really impacted in the pandemic, and then also how we are going to access these technologies. So the pandemic treaty talks about these points, and it focus on how we can have a local production of these technologies so each territory can deal with a situation like this, because this was a limitation. We had countries that produced, and then there were countries that received these products, and then there were others that received the vaccines in last. We also have a point about health workers. They should be protected, they should be trained to face certain situations, and of course, primary health care. So these are terms that are highlighted. We can wonder how these will be implemented, especially in global south countries. Then when we go to the tricky points, the ones that are not very clear, we think about how they are implemented. Also, if they are binding, because this is one of the big criticism of the drafts that we have seen of the pandemic treaty. Intellectual property in particular. So how intellectual property is a good, or if it is part of the world heritage. So we will discuss this later. How important the role of misinformation is. We have an infodemic term. These things that everyone is mentioning and things that we find on the internet or also on the press, and how this misinformation causes disbelief in government agencies that are dealing with the pandemic. And also when we are talking about strengthening, this I think is a positive point, this strengthening of capacity will belong to whom? Private sector, public sector? How is this handled from a financial point of view? So I think this is how I'm going to close my intervention, but this is a very general intervention, so thank you.
Okay, great. This is an introduction to the pandemic treaty. Thank you very much. I am going now to give the floor to Susana Barria. She's the secretary of the Andean region and a global coordinator of the International of Public Services, where the health workers are grouped. So go ahead, Susana, and thank you for being here. Good afternoon, everyone, and thank you for the invitation. It's such a pleasure to be here with you today, representing the Public Services International, that, as you have said, Mauricio, it's a union that is federated internationally with 700 unions representing more than 30 million public services workers, of which 60% belong to the health sector and care sector in general. So in that sense, we have followed the negotiations of the pandemic treaty, and we have tried to have an influence on the document ever since the process began. We have identified five key topics in which we would like to have an influence on, and one of them is the conditions of public funding for research that might protect the character of the results. We see this we see in this that universities support research, and the result is many times technology for health. But then this technology is usually privatized by pharmaceutical companies that set their prices and limit access. So on top of that, the patent rights and intellectual property rights are a key topic. And at the same time, the topic of ensuring mechanisms to allow international cooperation in the access to pathogens, data, and participation and distribution of the benefits coming from research. These three main topics are the ones in which we have been working on with the association, and we have worked with them with Third World Network colleagues as well. We know Gopakumar is here, but I'm going to focus now on the topics that we work with firsthand, being a union of health workers mainly. And I'm referring to the rights of health workers and health agents who were on the front line uh, with communities when the pandemic started and throughout it as well, of course. So, considering the visibility that these health workers, especially female health workers, had, we think that it's important to state that they need to have rights and guarantees in this treaty. We were witnesses of the sacrifices and difficulties that these health workers faced. But when the concept note of the treaty was published and the first draft was published, we realized that these rights were not included. There were considerations regarding the necessary qualifications for that workforce, but uh, their needs of protection were not recognized. So from then on, we have been working intensely and mobilizing uh, friendly governments as well in order to improve this. And we've had the opportunity to recognize that the Colombian government has been an ally and big support, particularly in the last negotiation round that started this week and will continue next week. Um, and throughout this work, we have managed to include some important clauses. First of all, we managed to include an article on health care workers in the draft, but we still need substantial dispositions regarding what their rights entail. Firstly, we want to integrate guarantees for decent work. Decent work has four pillars. One is the promotion of work so that we can ensure there is work, employment. The second is to guarantee rights at work, which includes the right to unionize and the right to strike and the right to a fair pay. The third is to widen social protection or ensure social protection. And fourth, promote social dialogue. So, in the context of the pandemic treaty, what we are asking for is textual changes that reflect these concepts. And what we're saying is that including efficient social dialogue mechanisms through two-party or three-party consultations is essential for there to be spaces in which we can address the necessities of workers, both in the planning and also in the response of emergencies, of health emergencies. So that is essential to reinforce the health systems because workers are right now within the system and they know the system, so they can make good proposals to the planning and to the responsiveness as well. So that is something that the guidelines recognize. We feel there is support about decent work, but we need more support for the elements that are entailed in that. So this is an opportunity to call the Colombian government to urge them to have a very strong support and to include as well an oral support. And next week on Monday, we will have a new text that we'll be working on in order to include social dialogue. Another essential element is to stop anti-union practices. We saw this during the pandemic. There was a lot of repression against uh, the attempts of workers to unionize, and Brazil made a proposal to try to stop anti-unionizing uh, clauses. So we are committed to the decent work agenda for health workers. And in terms of what we have managed to include is the following: language to protect the health agents, which includes the prioritization of having the adequate protective equipment. That is big achievement. We could see this in the difficulties faced during the pandemic. And of course, the objective was to safeguard their lives and to ensure there were elements to respond appropriately. It's important that we have included this, but we need to maintain this language in the text. Also, we need to address the need to um, we need to address the sequels that the health workers might have after the pandemic. We need to protect that in the text. We need this to be in the treaty, to stay in the treaty. Um, on the other hand, despite other proposals and civil society proposals to include clauses addressing the worries of the health workers and guaranteeing their needs, despite all that, and the need to protect migrant health workers as well. Despite of all this, the treaty is incomplete. So we have recommended to include clauses that respond make uh, countries accountable for protecting the rights of migrant workers and of health systems of different countries. So we call on the Colombian government to support us in this. And finally, in the context in which in which the pandemic with a new disease, there's always a bit of delay in terms of the evidence about transmission and infection, and this creates a situation in which frontline workers who are seeing the patient firsthand are at great risk of potential infections because there are so many gaps in the knowledge. So we think in that context, it's key to apply a principle of caution, of prevention and control of the infection so that we can protect the health workers. That means that we need to apply this principle of having some caution, additional caution, even if it's not established. I mean, if the causes are not clear, in the transmission or the disease, so that we can avoid the threats, life threats during the provision of primary care attention. And we haven't had support yet on this topic. It hasn't been widely debated in the associations or government. So we want to mention this and debate on this so we can get more support to advocate for this type of concept that might allow for substantial change in terms of the situation of response to a pandemic. So these are some of the key points that we are advocating for, and we are convinced that if we work together, we will be able to ensure that we will never again live or go through the tragedy of the COVID-19 pandemic. Thank you. Thank you, Susana, for sharing Public Services International point of view. I think it's very clear and it's very important to see that the health workers of the public system come from a pandemic experience in the frontline attention, and we have to recognize the importance of health workers for society. So I think your contribution was key, and these points have to be in the treaty. I'm going to now give the floor to Gopa Kumar, who is a legal advisor and researcher in Third World Network.
Thank you, Mauricio. Thanks once again for the university as well as PHM for organizing this webinar. I am thinking that it's a good opportunity to share what's happening here at WHO related to the pandemic instrument negotiations. So the previous speakers mentioned about it's a 9 days negotiation. This is supposed to be the last round of negotiation, and after this there is a strong logically also it may be correct there should be another round, otherwise it will not be possible to conclude the negotiations and taking it to its logical end. So having said this, now let's look at 3 or 4 important points. The first one is that what's the purpose of this instrument? We do have an instrument called International Health Regulations, which is supposed to capture all the health emergencies of public health emergencies of international concern, and help countries to respond to it in a way which is not affecting movement of people and movement of goods. But we all know that during the COVID, this instrument's loopholes came out. One of the important loopholes in the instrument is that it does not offer anything to respond effectively to a public health emergency of international concern. Let's keep away pandemic for the moment. Pandemic actually a very elevated form of a public health emergency of international concern. So if you have an efficient mechanism or efficient tools in your hand to contain a public health emergency of international concern, you may not even have a pandemic. Or to the elevation of a PHAC to become a pandemic can be in a way at least delayed. So we all know that the international health regulations basically obligates countries to provide information whenever the outbreak takes place. The countries has to capture it through their surveillance network and carry out an assessment provided under Annex 1 of the International Health Regulations. And they have basically the Annex 1 clearly shows how to make a decision. And according to the Annex 1, if that particular outbreak pose a public health emergency of
a concerned party has to inform WHO, then WHO will have its own assessment, and finally they take a decision whether to declare a public health emergency of international concern. But the problem here is that after declaration, there is no tools available. The country which is facing this public health emergency of international concern to respond effectively. So this gap in the IHR became very visible during COVID, and we did not have a legal tool, or we did not have an institutional mechanism to respond or to help countries to respond well to COVID-19 pandemic. So the idea was to create another legal instrument which to complement IHR, which not only looks at the preparedness and response, even prevention, much more effectively based on principles like solidarity, equity, CBDR, etc. Equity is most important one because the current IHR recognize that there is a development divide, but it fails to address that issue effectively, especially in the case of equitable access to medicine. So the new instrument is supposed to cover that. So this is the background of this new instrument. So we have finished around 8 rounds of negotiation. So this is the 9th round. But the truth is that this is actually the first round of real text-based negotiation. And if you probe further, whether there is any real text-based negotiation happening here, no, nothing happening. Countries are proposing textual proposals from the floor, and it is projected on the screen here. And different countries propose. Some country may propose, and the country may say delete it, or they may propose another language. So all these languages are compiled every day, and then it goes. So you have to now they are around Article 12, and they have to finish this kind of insertion up to Article 31. Then what happens is that the Bureau is supposed to produce another text. So by that time, it will be already Tuesday, and Wednesday and Thursday, 2 more days, and the INB 9 concludes. So that's why it's logically, it is important to have 1 more round or 2 more rounds to negotiate. And the member states are not allowed to negotiate, or there is no time to negotiate as of now. So this instrument is basically going to be an instrument cooked by end of this round. It will be an instrument basically cooked by the Bureau, and there is no real text-based negotiation is happening here. So these are the 2 points, and that takes us to the 3rd point. What's the problem? if if the text is a good thing, you don't have to negotiate. So what's the problem? What's the politics around this treaty? So this instrument, the politics behind this instrument is that the northern countries or the developed countries would like to use this opportunity or use this information to make a legal obligation on everybody, every parties, to share information on various kinds of information and on a real-time basis, including information on pathogens on a real-time basis. So therefore, they can use this information, or this information can be collected in one place, or you can use with the, this was the initial claim, you can use the artificial intelligence tool and you would be in a position to predict the next pandemic. Is that scientifically possible? No. But is then still this is the um, um, uh, position of developed countries, but they do not want to take any obligation either to establish this kind of huge surveillance infrastructure in developing countries, or to provide technology, or even to or even to share the benefits emerging out of processing this data. So as a result, instead of addressing the inequity, this instrument may lead to institutionalizing further inequity. And when it comes to the question of that's a fourth point, when it comes to the question of equitable access, there is no legal obligation which now guarantees predictable access to any of the health products or the technology. The only article which gives you some relief is Article 12, where under that is dealing with the pandemic access and benefit sharing system, under which any manufacturer who are party to the PAP system has to provide 10% of its real-time production to WHO on free of cost, and another 10% should be given to WHO on a not-for-profit price. So around 20% of the real-time production is supposed to be given to WHO, and WHO is supposed to allocate. That's the only guarantee. And for that, the countries have to basically to set it up a surveillance network on a day-to-day basis, and to collect data, and most of this data needs to be handed over and sent it to WHO or other international organizations that need to will end up in from south to north. So therefore, there is no guaranteed access, and at the same time, you are asked to undertake more obligations. So that is a situation where we are, and the current discussion today is on PAP system. That's on Article 12. It is very polarized. Even though the International Pharmaceutical Manufacturing Association talks about they're ready, they have given up their resistance on to have a PAP system. Now they recognize the PAP system, but at the same time, they're saying they're ready even to sign a legally binding obligation to provide some part of their production, but they are saying they would like to have unconditional access to pathogens. So this means the signing will not be conditional upon, should not be made as a condition for providing access to pathogens. So this goes against the principles of CBD and Nagoya Protocol. So we are in a stage where in which right now there is not enough time. Many countries are pushing that they would like to have the treaty by May. But at the same time, if you go by the content, it is almost impossible. It's running against the time, and therefore it bears the danger of reinforcing iniquity. So let me stop it here. Yeah.
Well, So we have just heard Dr. Pakumar's perspective, showing what are some of the difficulties of this global treaty. There are different interests involved, and in a situation like this, of course, they are there, and they make coming to an agreement more difficult. And of course, there's the risk of favoring those who have more power. So I will now give the floor to Dr. Claudia Vargas. She is professor of the pharmaceutical school at our university. She's also a pharmacologist, but she currently works at the Ministry of Health. So, Dr. Claudia Vargas, you have the floor so you can present the national government perspective on this topic. Miguel, can you upgrade Dr. Claudia Vargas to panelist? It takes a moment. Thank you, Miguel. Dr. Claudia Vargas, you can now begin. So let me remind you, if you're on YouTube, that you can make comments and questions, and then in the next section, we will address them. So thank you for being here. Hello, everyone. I'm sorry for the inconvenience. So just to give you some context, at the Ministry of Health, the Drugs and Technology Directorate has as one of its responsibilities to address intellectual property situations that affect people's health. We have been working hand in hand with the Geneva mission to establish Colombia's position in these discussions on the pandemic treaty. According to what the panelists have already said, it has not been an easy negotiation in Colombia since 2022, when there was a change of government. We started proposing a different opinion compared to the previous government's position. And Colombia's position has been first that in this discussion, the right to access to health should be at the forefront. If what prevails is commercial interest, then we will never have a response that guarantees the access to health care to everyone. Maybe the most difficult moments have been everything connected to intellectual property and facilitating access to intellectual property. If I'm not wrong, I think this is Article 11, which has been one of the most complex articles that have had the most resistance from rich countries. We have also kept a position regarding access to genetic resources, but above all, that distributing benefits is still equitable. I mean, a country that facilitates access to a pathogen, that's already established, but then everything else connected to technology, vaccines, and so on, that, I mean, that should not be private, so that countries don't have access to them, and they cannot respond in a potential pandemic. So this has been critical because we don't want to repeat everything that happened during COVID, because access to the pathogen was limited and there was a huge investment from public funds to have a very quick response, but then in the end, everything was private. So there was no fair access and the costs were very high. That's also something that has been mentioned in the treaty prices. Everything that is done in the context of an emergency, it has to be available and free. It cannot be confidential, and this is what happened during COVID. The access to benefits, and another point that has been discussed related to intellectual property has been protecting healthcare workers. We at the ministry want to keep this as a warranty. The discussion has been very difficult, and one of the things that has caught everyone's attention is the change of position, because Colombia historically has been aligned with the United States, but now we are aligned with global South countries. And we've had to explain and say that we don't want to repeat what happened during the pandemic. This has to be something that we have learned from that situation. And we are all worried about what Gopa was mentioning. The treaty might be more complex, and perhaps the outcome will be more complex than what we already have. So that's why we are still supporting the mission, so that the base is that the right to health is above everything. I mean, that's what should happen all the time in any situation, but in particular in an emergency. That's how we should be working. I don't know if, well, this is briefly what we have been working on at the Ministry of Health. I'm not sure, Mauricio, if we should move on to the Q&A section, or if you need more details. Okay, thank you, Professor Claudia Vargas. Thank you for your words. So, yes, I think that the idea is to have a conversation. I think it's clear how important a text like this has, based on the experience that we had with a global pandemic like COVID-19 pandemic. As some of you have mentioned, we have the experience of the international health regulations, which allows some joint actions between countries in the field of public health. And these are not exclusively territorial or national, but actually these problems are perhaps regional or global, like COVID-19 pandemic was. And also these agreements between countries, so that we can respond to emergencies and situations like this that put people's lives at health, and actually life on the planet at risk. We had here 3 important people, specialists in this field. We need to understand health as a basic human right, that it should apply to everyone with no barriers, and that includes a financial barrier. And it's also important to understand health as a public asset, a common asset. This is a key concept, and this means that scientific and technological developments should not be restricted based on who can pay for them or not. And this involves intellectual property rights. And we also have the topic of work, and I think this treaty should include this topic so that we can protect work conditions of health care workers who are dealing with public health situations for everyone. I don't know if we have any questions from the audience. I don't see any on the chat. I don't see any questions on YouTube either. So then I would like to ask you maybe to go more into details how important this treaty is, and if you can, from your perspective, if you can say which are the agreements available and which are the disagreements that should be worked on when we think about these concepts that we use to analyze this pandemic treaty. So here I have a hand. Oh, this is me, Mauricio, Miguel. So there are two questions in the Q&A bottom. There's one in English and one in Spanish. Can you see them? Yes, I can see them. If you can help me with the one in English, okay. So then we have first Juan Eslava. He makes three questions. So when and how did the discussion on the treaty start? Second, who have been the main characters in the discussion and what have been their positions? How possible it is that this treaty overcomes the imbalance of international power and economic interest. Some of these things have been mentioned, but I think it's important to provide some details. And then we have Agum Prakoso. He also asked some questions. If you can help me, Miguel, with that. So I will now open the Q&A section so you can share what you think. So, Juliet. Well, regarding, well, it's a bit tricky. Well, so when this start, it was in 2021 when the Intergovernmental Negotiation Body was created. So all member states of WHO participate, and there was also an invitation to NGOs from civil society to participate. I think perhaps Susana, Professor Susana, she can share with us how did the two international units, how did they get to participate? Well, regarding what you were saying, Mauricio, there are a couple of things that need to be highlighted right now. And this is one of the biggest criticisms that the pandemic treaty has faced. The treaty is handled in a way that it's not legally binding, So some things have to be fulfilled. For instance, the participation of the benefits of pathogens to create any kind of technology, maybe for diagnosis, treatment, or for medical devices. We don't see language that suggests that this is mandatory. So right now, this does that the solidarity of the treaty is still based on each country's willingness. And also, the idea is that each country has more health sovereignty, but the treaty mentions this in a very general way. For example, in the International Health Court, we had a discussion in which we said that this kind of instrument tries to make world population the same, and making world population the same doesn't take into account how pandemics, pathogens, outbreaks, how all of these things will be determined by social, cultural, and economic aspects in each country. So how each country could or not adhere. Perhaps it has to do with the government that they have, and well, so on. So these are all conditions for them to participate. And the other question, the other thing that I would like to say with Claudia, the part about the agreement of intellectual property protection, everything that has to do with trade, because here we are talking about health, but then we also include the commercial aspect, and in the text, what we can see that it's not binding, that there should be a flexibilization with patents, and when we are talking about an emergency, but flexibilization is not truly clear in the treaty. Thank you.
Okay, thank you. Susana, you have the floor. Thank you, Mauricio. Well, as Juliet was saying, I am also going to reflect on the contributions to the process. It started in 2021 with the creation of this intergovernmental agency for negotiation, and this is a very important part. It's an intergovernmental process, and the leaders are the governments. But in the different stages of negotiation, I've seen that after 2022, um, consultations were included in the framework of WHO discussions. There are civil society organizations that are recognized in official relationships with the WHO, and every time there are different processes, these organizations have a place to make consultations, but they are not taken into account. They are not part of the official negotiation. This process was considered to be special, and so they opened the process to the civil society. But the consultations made by these organizations that are having an official relationship, they moved to a new phase of negotiations during 2023, and that is when the space closed So the textual negotiations are being carried out behind closed doors with governments participating only. So to support these processes, we have to do it through the governments that are interested and which collaborate with us. So we need to think about the other question of whether there is a way to overcome the power relationships. And I think these international treaty processes, they localize these pandemics are these pandemic treaties are inside the power relationship. It doesn't happen in a vacuum, in a space that is different from geopolitics. It happens in a context, and there is representation of many countries or all countries sometimes, and they want to build their legitimacy, but there is no real representation for all countries. It depends on their capacity of their delegations, on the size of their delegations, on the possibility that their delegations can travel to Geneva every time there are negotiations. So there is inequity. I wanted to go back to the question of advancing in terms of intellectual property and in inequity to technology access. I think what Gopal said is quite clear, and I agree with it. We are blocked in the global south, and that is an issue. So I think we also have to consider that on the side of the health workers' rights, we have been able to advance. So it's important to keep on working there because that part is less controversial, maybe. And in that sense, I want to invite Claudia Vargas to make a comment on her perspective about her perspective of the Colombian government's agenda, which is quite committed to decent work and employment. And in the concept of decent work, we can also include the right to unionize and the topic of social dialogue. So we would like to hear about the position that the Colombian government is taking on the face of these proposals from other countries to include recognition to the importance of dialogue and to ensuring the limitation of anti-unionizing practices. Okay, thank you, Susana. Gopa, you can go ahead.
Hello. So can you repeat the sort of question? So I just missed in between. There was some audio.
Well, there were many questions, but maybe to summarize for you, Gopa, you could focus on the protagonists. Who are the protagonists? And I add a question that was made now, which is, do you know anything about commercial lobbies within the discussion of the treaty, and in particular the pharmaceutical?
Yeah. I think definitely it is the main industry lobby which is active on this issue is pharmaceutical industry. The pharmaceutical industry mainly led by the originator companies, that's IFPMA. But at the same time, IFPMA would successfully roped in all the generic industries, even of the global south, including the developing country vaccine network manufacturers network, also part of the they came out with a joint statement in which basically they are saying that they would like to have unconditional access to the pathogens so they can develop new vaccines, and at the same time they say that okay, they would share some benefits, but on condition that it's the access to the virus or pathogen should be unconditional. Regarding technology transfer, IFPMA is basically saying it should be on voluntary, voluntary and mutually agreed terms. Like institutions like MPP, they are not ready to have any kind of um, other mode of transfer of technology, such as one of the demands is to transfer of technologies to WHO of those products which are funded by the government. So as we all know, most of the pandemic related products or infectious disease products are developed through the public funding, as in the case of COVID. Substantial funding goes, but it's all in a way owned by pharmaceutical companies through patents and other mechanisms. And though there are policies in countries like US where in which government can march in, but they don't exercise. So what actually happening is that the privatization of the profit and socialization of the risk. There are proposals in the pandemic treaty on Article 9, Article 11 regarding what the public funded R&D. So the initial position of developing countries is that there should be an unconditional transfer of this technology to WHO or even manufacturers in developing countries, at least during the time of pandemic or PHEIC, so they can have the production of these products and to achieve something called diversification of the product instead of a highly concentrated production of these products in a few countries. But industry is opposing that, and even the developed countries are opposing. They say that it can be only through voluntary and mutually agreed terms. There are specific provisions proposed which they say very, it's not changing the status quo. It's basically say, hey, you publish the conditions under which the public funded has been provided, which say that, okay, you have to develop policies with regard to licensing of technologies, but that does not guarantee the technology. So that's the problem we are facing. Yeah, thanks.
Okay, Claudia, Professor Claudia. Okay, so taking the questions into account and regarding the position of the Colombian government, I would like to say the following. The stance that has been taken is that the right to health has to prevail over commercial rights so that we can have an appropriate response. So we have had a position that is aligned to that budget, which is that we need to facilitate the transfer of technology, and maybe a controversial point has been that the technology transfer has to be at all times and not only during emergency, right? Between pandemic periods, we need to transfer technology because it takes time. We can't do technology from one day to the other when we are in the middle of a pandemic. So this is what happened here. We had a big capacity for vaccination, but when the pandemic came, we couldn't respond in that sense. So that was one of the critical points for the country. And then flexibilization of intellectual property rights. The waiver was discussed, And bilateral agreements are really slow. They are not efficient, and that is not the response we need in the framework of an emergency. So, in that sense, we have established the need to make these transfer more flexible. And one of the key points that we have discussed is that the intellectual property rights are not acquired per se, but rather they are rights that governments give. Sometimes we forget this. Sometimes we think that the patent of a technology is a sacred word and you cannot touch it, but we have to reinforce that aspect. It is governments who define what is protecting, what is not. And there is some flexibility in the agreement, but in our experience, we have seen that these agreements are not efficient or quick, and in the framework of an emergency, uh, the process is really delayed, and we cannot have a timely response. We were also discussing access to knowledge and information. It is information what allows me to determine my strategy and my decision making and the reach or the scope of my response. So w- that topic has been under discussion. Open science for these types of situations, because that was a barrier that made it more difficult to have an adequate response from the population. In with regards to workers, the government wants to promote health workers' protection, considering that they were one of the groups that suffered the most. They were suffering the most consequences because they are the ones who were in the front line. And regarding access to the genetic resources, there is a treaty that in case there is an emergency, we have to uh, allow for access to pathogen. But then you cannot privatize technology developed from the information that I am giving you. You are protecting that with intellectual property, but you are depriving me of accessing that technology. So that is the problem. That is the stance we have taken in the government and the stance we have defended so far. Oh, thank you. Intellectual property rights are definitely really important, and we have to keep on fighting because these processes will establish common goods that cannot be patented, and they can be up for anyone, and not to favor the economic interests of certain sectors. We lived that experience through the pandemic, and it was paradoxical because much of the research to develop the vaccine were done with public state resources. And so the vaccine was then managed as a private good. So that is key. Um, the government position and the society position is important. We need to challenge this issue. I'm going to read some of the comments that were made on the chat, both in Zoom and YouTube. Ricardo Ramirez from Ecuador says, it would be great to elaborate a manifesto addressed to the government and for it to be published in each country so that the representatives can act advocating for the right to health and life, and they are not um, subjugated to the interests of world capital. Uh, this type of treaty has consensus as an objective, or will the voting of the majority be making the decision? Is that the case? Do some countries have more weight, or is there equity in in the the voting? And then Juanislao says, okay, relationship power exists, but the question is, we need to overcome two problems: commercial interests in the face of intellectual property, and secondly, the imbalance of power in pharmaceutical markets. Kat Ersa from Philippines says, do you think there should be no patent or patents be removed for pandemic technologies during a pandemic? And secondly, is it just or fair to mandate countries to make healthcare free, at least for systems that have mixed public and private during the pandemic? Brandon Ricardo says, kind regards. Professor Juliet mentioned that the treaty tries to incentivize local production of biotechnology. How do you intend to develop this proposal without solving the conflict of interest regarding intellectual property? And finally, Juanislava says, improving the international treaty demands a reform of the current health management internationally. Is there political interest to do that? And then some comments on YouTube. If this treaty signs solidarity commitments based on will and technological transparency, mandatory benefits, etc., will it be signed? And Diana Sulima, she comments or invites people actually to see the bulletins that have been developed in uh, the Center of Medication Information and Power of the National University. So these are the comments. There are more questions, but if you want to take them into account, that will be okay. We have a last round of interventions, so I'll give the floor to Dr. Claudia. Do you want to add anything?
Well, regarding the questions, I think, well, what I want to say again, the position that we have been mentioning, discussing intellectual property is very complex, many interests involved, but I think that the fact that we are talking about this, that Global South's worries are now being mentioned, and that we are more united in the sense that we all need this treaty to solve a problem in an emergency. We don't want to go through the same situation that we went through during COVID-19. So this has been important on an international level. And especially in the context of what happened during the waiver, the intellectual property waiver discussion, specifically for medication and diagnosis methods, it shows that it's necessary to be clear about the intellectual property aspect in the treaty. We cannot just provide an answer without making sure that there is technology available and that everyone is aware of the know-how, that all countries have the same possibilities. So I think that's what I would like to say to close. This is what the government thinks. This is aligned with the government plan on development and health and what we are doing at the Ministry of Health. This is what we're doing with an IHV drug, for example. And this is what we're doing to defend the country's position. Thank you. Gopa? You have the floor.
Hi. Thank you. I thought that I'll deal with a slightly different but linked process. As I mentioned, international health regulation. Actually, WHO member states are amending international health regulations, and one of the mandate for this amendment is to address the equity issues uh, within IHR. So that negotiation is happening. At the same time, there is a related issue comes up. What is the status of this pandemic instrument? Whether it's going to be treated as a separate international treaty or is to be equally with under no, like with IHR as a regulation under Article 21 of the WHO Constitution. So in that case, it's important to understand that the scope of IHR is much broader because it covers all the public health emergencies of international concern. What we are dealing with this instrument is very small part of it, that's pandemic. So therefore, it's important to ensure equity. We should have equity in IHR, and this new instrument should not result in any kind of fragmentation of norms or finance or governance with the IHR. So therefore, it is better to treat this instrument also on the same normative and legal footing with IHR rather than making it as a treaty. There is one more danger. If it's a treaty, every country has to ratify. The countries who are not happy with the instrument may not ratify this treaty, especially US will not ratify. So the equity provisions where we are talking about may not be operational or effectively operational. Legally, it might be operational, but it may not have enough effect. So we need to also think about as we move forward, where this instrument should be anchored. So this is an important issue. I just leave it now for you to think about it. So a lot of hype is there about the treaty, but it also has a lot of pros and cons, and we should be mindful about that. Otherwise, what's going to happen is that a certain number of countries will be part of this instrument, but they don't have other set of countries. They won't have that kind of obligations, and legally they would be outside this instrument. So that kind of situation we should avoid. Thank you.
Thank you, Gopa. I think what you mentioned is very important. The difference between the international health regulations and the pandemic treaty. We need to make the scope as broad as possible, and that it is aligned with the IHR. So thank you. Susana, please. Thank you, Mauricio. I want to say as something connected to how decisions are made, because we are in a context in which, even though we talk about one country, one voice, the intention is that decisions are made through consensus. So this is not the same. And we also have these power relationships, power dynamics, and also the power that the WHO Secretariat has when there is no consensus or when there is consensus. And this becomes much more complicated in this context in which we're talking about a controversial topic. So this is controversial. We have seen, for instance, that language in the first version of the treaty that started to dilute. Even though there are some global south countries that are working in the direction of intellectual property rights, and we could not really see where this was coming from. But we know that big pharma companies were pretty central in this discussion. But this happened with a process of influences and, well, the WHO Secretariat. When we look at the discussion connected to healthcare workers, right, what happens is that many countries say that they're committed to this. But if whenever a proposal comes up, there aren't enough countries that are going to support this proposal, then we see that this doesn't have a consensus, and it seems that only one country supports this, or maybe two countries do. So, for example, in the case of Colombia, that they are committed to having decent work conditions, this has to be felt. So whenever somebody mentions healthcare workers' rights, migrant workers' unions, we need Colombia to speak up. And last week, Colombia did not do that enough. And then on Tuesday, when there is a new draft, Colombia needs to be more vocal when it comes to these topics. And I also think it is very important what Gopa said between the relationship between the treaty and the IHR, and that this treaty then needs to be ratified, and there are some advantages there. And also that any amendment, well, has different consequences. So sometimes we forget that in order to have equity, we also need healthcare workers' rights. And for that, international health regulations are very weak. We need more proposals. We've had proposals twice in the framework of the treaty. So we need this in the context of international regulations for healthcare workers. Thank you very much for this discussion. Very interesting. Thank you, Susana. So now, Juliet. Thank you, Mauricio. I wanted to go back to some of the questions that you shared. Answers are difficult, but we try to, well, approach different things at the same time. First, what Claudia was saying regarding the capacity generation, we had to do that between pandemics because responding to an emergency when the emergency is already active, that's what causes chaos. And that's what happened with COVID. So then how do we do this? What policies are we going to implement? I'm a professor and researcher, and what I see are projects on royalties and these actions that try to build capacity. But if we think about how we're going to do this, we should do this more specifically. Also, when we talk about public resources that is patent, this is a background difficulty that we have in the context of university. So we normally do the basic part in public institutions, education context, but then when we want to create a product, well, it leaves the education sector. So we are working with different treaties and agreements between the state, companies, and universities so that these public resources can reach different public initiatives. And this is connected to how the treaty tries to make all populations the same. There's a problem with resources getting to the public sphere, and it's a structural problem. And then regarding biotechnology and how we're going to solve this, and the answer is, I don't know. I'm not sure. I don't know how we're going to solve this issue, but Colombia has capacity in the sense of generating development, but what sometimes happens, at least from a research point of view, we are lacking money. So we need to see how the state, and actually the state is doing this, because the state is investing, we need to see how we can adapt to health plans, development plans, and also to go back to certain initiatives connected to, for instance, what Claudia was saying. We had some capacity that was not supported anymore. So once the pandemic hit, well, it did not work. So we need to think about the context of the treaty. So all these little things that we have here in Colombia. And I want to thank you for this space because I feel this was a very enriching discussion. So thank you very much. Thank you, Professor Juliet. You're very kind. So we've had some comments, some questions. They have all been answered. And well, this a process like this is complex, diverse, and full of subtleties and perspectives. And it all depends on where you are looking at the topic from. And there's something that appears in all the questions, the interest involved in a treaty like this one. There are public interests, private interests that move differently. But they are the ones that, eventually define the decisions. Something that I wanted to highlight because I think it's key in a situation like this, which is health sovereignty. This is something that Dr. Claudia mentioned. The concept that current government has been working on. It's fundamental for countries because it gives countries the possibility of having the capacity to answer in public health situations, but it also involves not being able to access certain resources and development. We need articulations, collaboration between countries so that we can move forward and respond with a public perspective and not a private perspective. And in some of the questions and comments, you mentioned it. In South America, we have been working in that direction with the different regional relationships and the experience that we have with UNASUR. And the ISACS was an institution that was created that tried to strengthen national capacities from UNASUR and to provide joint responses in different public health situations. And they would jointly buy drugs and vaccines. Some of the experiences will also try to provide joint responses to different public health situations. And these are key experiences that we need to continue strengthening. From a global South perspective, we should also collaborate and think jointly about this health sovereignty topic, and also to face commercial interests that are always involved in these situations and become huge barriers to finally access goods and services related to public health issues. So I think this is something that permeates throughout this debate. And of course, we need to continue working on this in different contexts. From a people's health movement, as I mentioned at the beginning, we have been working on this topic. I invite you to go to their website because they have some documents that cover these topics. And I also wanted to mention that PHM has been developing an initiative for a very long time. So they have a tracker. They track discussions and decisions made by WHO and what is discussed at the WHA, the World Health Assembly. I think it's very important because we can see the dynamic global discussions, and we as a university, we want to participate in this initiative, and we want to support with our analysis so that we have more elements to analyze, and that other organizations from civil society and also the government can participate in these debates and discussions, so that the decisions made at the World Health Assembly are the best and try to guarantee access to health. And we can consider all that health is a common good. So these initiatives are all included in People's Health Movement's website, and you can all access this website and share with other people too. We're going to then wrap up here. I want to thank all the panelists. I want to thank Dr. Juliet, Dr. Susana, Gopal Kumar, and Claudia Vargas. Thank you for participating. I'm very sorry that Dr. Roman Vega could not join us due to technical issues, but well, sometimes things go that way. I want to thank Albert and Miguel's technical support in this webinar, and I want to encourage you to continue participating in these spaces and debates in different social, union, academic, and state spaces. So this pandemic treaty and other decisions actually allow everyone accessing health. Thank you, everyone, and I'll see you again in the next debate.